Okay, now regarding the vertical dimension, it's very important that the patient has enough room for the lab to make a crown. Now, generally, this cannot be done in the mouth. We have to make an impression of the upper jaw, of the lower jaw, send it to the lab, and they will send us an articulated model. Then we will measure with the ruler the distance for us to be able to, if do we have room or not. So now, to avoid that, imagine we are missing a premolar, for example, and the patient comes with a missing tooth, right? In few seconds, maybe 1 second, we know this is 7 millimeter, and we hold it not horizontally, vertically. When we hold it vertically, if this goes in, that means I have 7. That means I can do a cementable restoration. But if it doesn't go in, I have to think of screw retained. Okay? Even with the screw retained, I need 4.5 millimeters. So I go to the 5 millimeter, which I showed you before. I go to the 5 millimeter space. Even if 5 doesn't go in, that means I need to either do increase in the vertical dimension, or I have to do extrusion or intrusion. I have to do something. Now, sometimes the patient comes with very little space in the back teeth. Let's remove this back teeth. And let's say the patient has very limited room when the patient is biting. But how to measure this? I have my 3 millimeter. You remember this side was 3. So I pass it. If 3 millimeter goes in, okay, I know impossible for me to do a screw retained here because I need 4.5. Then I make it vertical for the 5. If the 5 is not going in, I have to increase the vertical dimension somehow. And if the 5 is going in, I only can do screw retained. So I pay attention. I don't have room for multi-unit abutment and so forth. I have to use either dynamic abutment or tie base or pre-milled abutment and so forth. So at the time of diagnosis, it's very necessary to have a tool which gives me all the possible things that can go wrong, either during the surgery or during the restoration at early stage. So let us continue on different scenarios. For example, the patient comes with a missing lateral incisor. Okay? And as soon as you see the patient, you tell the patient, yes, I will give you an implant. Okay, fine. But you don't know the distance between mesiodistally in this area and this lateral is exactly the same or not. Because at the time of restoration, if this is bigger and it doesn't match the other lateral, the patient will complain. So the right way to do it is to send this to the lab for a wax up, which costs and it takes a few days. But with this part of the DiDi, the flexible tip, you can place it exactly this. Let me hold it up. Yeah. You can place it like this, and you can see here, if the space is different, then it will not fit perfectly the other side. You can see it right now at the time of diagnosis in the first 3 minutes. So it's very helpful to get an idea of the golden proportion between all the upper teeth in few seconds. Say 2 teeth are missing. Same thing. You can see if these 2 teeth, you can see this curvature. And because it's flexible, you see when you press it against the teeth, it actually changes its shape. So it actually takes the shape of the arch, because people come in different sizes. So that's why it's very helpful to have a wax up, universal wax up for all your anterior cases. Now, this is useful in diagnosis and at the surgery stage, where you want to be away from the labial surface of the tooth. Now, we can talk about at the time of surgery, If you are a flapless person, you want to do punch, or you're against punches because you want to preserve the thickness of the soft tissue, you can do a half a punch. I prefer half a punch. I try to avoid using a full circle and throw the gingiva away. I like half a punch. So what we do, we place this half a punch this way on the soft tissue area, and with our thumb, we press on it and rotate it. We have a very clear imprint of this sharp object inside the gingiva. And of course, we need a blade to go all the way to the periosteum and reflect it labially. And then we do our surgery and we can put it back, or we can tuck it inside the labial fold to make a thicker keratinized tissue on the buccal side. It's up to you. The point is, we can make an exact dimension, which is 5 millimeter, all the time, and our hand doesn't slip or we don't make an unnecessarily big cut. Every time we do a surgery, we have a half a circle of 5 millimeter to have the minimum exposed periosteum for better healing. Now, at the time of uncovery, there is another technique that we have come up with, and that's an etch. It's not a U shape anymore. It's the other side, which is an etch. This etch is ideal for uncovery stage. According to the thickness of the keratinized tissue that you want, you can place the etch as palatal as you want. When you place the etch on the gum, say there is an implant here and you want to do uncovery, instead of making an incision and opening a flap, you take this etch, you press it on the implant, and you press as hard as you can, and you make sure it's very deeply placed. It will make a cut inside your gum as an etch. So you place half of that etch palatally and the other half labially. And then that thickness doesn't require to be sutured. You do your uncovery, you make your impression, you place your healing abutment, and you leave it as it is. And that will heal beautifully, because once you start suturing, you actually are tightening the blood vessels unnecessarily, and they cannot heal. And once they're supported with the healing abutment, actually there is no reason to be sutured. The reason you suture them because you made a big incision without support. That's why it bleeds and you need to suture them. So this etch is very helpful, again, because it's a 5 millimeter mesiodistally, and you decide how much of a buccal keratinized tissue you want, and accordingly you place it here or here or here, wherever you want, and that area will come to the buccal. Whether you leave it on the buccal or you tuck it in by doing a roll flap, it's up to you, but it does not make you to make an unnecessary suture, and it doesn't make you to make an unnecessarily long incision for every uncovery. You might say, what about a full mouth with 6 implants? Isn't it easier to make one full incision from beginning to end and open everything? I kind of disagree with that, because if you place the etch in each and every one, the other gingiva that there was no reason for you to cut them, it will not require a long healing period. With this etch, next week when the patient comes, the area is ready for your impression. And it's definitely less painful for the patient to heal, and no sutures placed.